Okay, great. Well, it's just about 5 minutes after the hour, and if it's all right, I think we'll go ahead and get started with the presentation. I want to again thank everyone for spending some time with me this evening, learning about a topic that is very important to my practice of medicine, which is, of course, in general, urologic care, and then specifically what we would term men's health, which is a broad term that encompasses a lot of different things that we're going to talk about tonight, of course, including erectile dysfunction. For those of you who logged in after the sort of initial introduction that I made, as you can see down at the bottom of the screen, there's a little chat box. Any questions that you might type into that box will come to me alone, and I will plan to address during the presentation. Anything that I don't have a chance to address during the formal presentation, I'll be happy to do so, of course, at the end. There's already been a very appropriate question that I should be very clear about, which is whether I can see the panelists, whether I can see the participants or not. And the answer is no. I'm able to see the presentation. Obviously, I can see the screen that has sort of my face in it. I cannot see any of you. Hopefully, you can all see and hear me. And any questions that are typed in the chat area will be private, will not be seen by any of the other participants. If we could have the next slide, please. So just a real quick sort of overview of who I am and what my interest is in this specialty, my training and background. Obviously, that's an old, let's call it pre-coronavirus picture where I was actually allowed to have a beard. Now with all the mask requirements, that's had to go away. But I'm a board-certified urologist, been here with Central Ohio Urology Group for the past 10 years. I grew up here in Central Ohio, graduated from Columbus City Schools, did my undergraduate education at Case Western Reserve in Cleveland, came back here to Columbus for medical school at Ohio State, and then spent 5 years in Chicago at Rush Medical Center, where I did my urology training. I really subspecialize in a number of men's health categories, including, of course, erectile dysfunction and the management and surgery for that. In addition, things like Peyronie's disease, testosterone, as well as, of course, many of the common things we see in urologic care, enlarged prostate, urinary leakage, and things of that nature. If we could have the next slide, please. So the overview for this evening broadly is to speak about erectile dysfunction in terms of what is it? How do we define erectile dysfunction? We're going to talk a little bit about who has ED, and my hope and expectation is that I impress on everyone how common ED really is, and how with more representation in our lives and in healthcare, we're realizing that this is a very common disorder. And then what causes it? What are some of the things that occur in terms of our medical problems that lead to ED? And what are some of the things that we as urologists might do in efforts to treat one problem that ultimately might lead to the trouble of erectile dysfunction? We'll, of course, then transition to a comprehensive conversation about what are our options, what treatment methods do we have available to us, and we'll move forward from there. So we define erectile dysfunction as the persistent inability to achieve or maintain an erection firm enough to have sexual intercourse. Sometimes when I read this definition, I have one slight modification that I would make, and that is to say firm enough to have sexual activity, understanding that each man defines sexual activity differently with his partner. This is an incredibly prevalent problem. We can read here that approximately 20%, 1 in 5 men over the age of 20 will experience ED in their lifetime. And more than half of men over age 40 have some degree of erectile dysfunction. The classic statistic that we that we go to is that 50% of guys who are 50 are going to have erectile dysfunction, 60% of guys in their 60s, 70% of guys in their 70s. So it becomes more common to have erectile problems as we age than not. But of course, in my practice, I take care of men every day who are in their 20s and 30s who are starting to have erectile issues. So this is really can be a lifelong issue for many men. And as you can see, affects at least 39 million American men, although unfortunately that number increases, of course, every day. So let's talk a little bit about how it is that we achieve an erection. Of course, for the majority, certainly of our younger lives, this is just a magical thing that happens when we want it, sometimes when we don't want it, but nevertheless happens without us having to work at it at all. But in reality, there's quite a bit that's going on sort of behind the scenes that allows us to achieve an erection. It all starts, of course, with some form of sexual desire that causes nerves in our brain to fire. Those nerves send signals that travel down the spinal cord, ultimately sending signals to the nerves that surround the penis. Those nerves send a signal called nitric oxide. Nitric oxide is a very small, actual physical compound that leaves the end of the nerves, binds to the wall of the arteries around the penis and in the penis, telling them to dilate. As those arteries dilate, of course, blood flow rushes into the penis. And we can see here on this illustration that in the flaccid state, there is potential for blood flow to the erectile bodies of the penis. But as those arteries dilate and the blood flow really increases in the erectile bodies of the penis, that's when we begin to achieve the erection. In an ideal circumstance, as the erectile bodies of the penis fill with blood, they compress the veins that drain blood out of the penis. So we have lots of blood coming in, very little going out, and that's what gives us, ideally, the rigid erection. So unfortunately, there are a number of things that are associated with erectile dysfunction that are also very, very common for men to experience throughout their lives, and really are the reason that ED becomes so common as we age. So the top three physical causes that are associated with erectile dysfunction are vascular problems, which is just a fancy way of saying blood flow. So this is the classic sort of cholesterol blood flow issue that might lead to heart disease, it might lead to peripheral vascular disease, but it leads also to erectile dysfunction. Diabetes is a major cause of ED, as we'll talk more about in a few slides, because diabetes affects the ability of our nerves to send signals telling the arteries to dilate. It also makes it so that the arteries don't dilate as efficiently as they should. Medications can often cause a problem, most commonly blood pressure medications, which, to be clear, is not me saying that we should stop blood pressure medications. They're absolutely vital for heart and other vascular health, but it stands to reason that if the blood flow pumping into the penis has less force behind it, we may not get as good of a flow as we would otherwise. We also know that, unfortunately, ED can be secondary to things that we as urologists do in an effort to cure disease. Prostate cancer treatment, also, in fact, benign prostate treatments can often lead to worsening erectile function or the development of ED. Heart disease, of course, we have to be aware, as I mentioned a moment ago, that the same process that leads to heart disease also leads to erectile dysfunction. But we know that ED might precede heart disease by several years, which is to say that if we develop erectile dysfunction, that means that we should really be focusing on our heart and vascular health to avoid the development of heart disease 10, 15, and 20 years down the line. So let's talk a little bit more about the relationship between erectile dysfunction and diabetes, which, of course, I'm sure many folks on the presentation this evening can say is a very common problem. So 15 million men in the United States are known to have diabetes. And of course, that's data that will be updated with our upcoming census, where we expect the numbers are going to be even higher. Unfortunately, 50%, so 1 in 2 men who have diabetes are going to have sexual difficulty related to the diabetes. And we also know that men with diabetes have more severe erectile dysfunction than men without diabetes. And the treatment of erectile dysfunction in men with diabetes is, quite frankly, more challenging, which is to say men may not respond as well to medications like Viagra or Cialis as men who do not have diabetes. In addition, it tends to affect guys who are younger. Unfortunately, I saw a patient of mine actually yesterday in the office who is a lifelong type 1 diabetic and in his mid-30s has severe enough erectile dysfunction that we're seriously contemplating something like a penile implant. And the reality there is long-standing diabetes, even when well controlled, unfortunately carries with it the risk of worsening erectile function. In some men, I think it's worth saying that ED can be the presenting symptom of diabetes. In fact, in urology, it's fairly common for us to diagnose men with diabetes because of the urinary symptoms and, of course, here the sexual symptoms that can be associated with the disease. So as we talked earlier, diabetes makes it so that our nerves don't send signals as efficiently as they should. Sometimes this shows up as burning in the hands or feet, or what's called neuropathy. Neuropathy is simply the physical pain that is associated with the nerve signaling being somewhat abnormal, but that same issue can lead to erectile dysfunction. Because if the nerves are not carrying the signals to the arteries, telling them to dilate, then the arteries will never know that it's time to dilate, and we won't achieve erection in the appropriate way. There's also some damage to the blood vessels themselves that occurs because of the sugar in the bloodstream being deposited in the blood vessels, making it so that they cannot dilate as efficiently as they should. And so since our pills for ED, Viagra, Cialis, things of that nature, since they require the nerves and the arteries to be intact in order to work, that communication between the nerves and arteries has to be there for the pills to be effective. So that's why men with diabetes oftentimes don't respond to the pills the way that we'd like. So certainly age is always going to be a factor in increasing our risk of erectile dysfunction with and without diabetes, but certainly the longer that we've had diabetes, the more potential, shall we say, damage to the nerves and blood vessels can take place. Poor glycemic control is just a fancy way of saying if the blood sugar is too high, that's bad. And the longer that it's high, the worse that it is. Presence of microvascular complications essentially just means that if we have some other blood vessel issues related to diabetes, if we have decrease in blood flow to the legs, if we're having issues with blood flow to our eyes, which is common with diabetes, that is likely going to be a representation of erectile troubles as well. Diuretic treatment, sometimes patients with diabetes are on water pills, and sometimes that can increase our erectile dysfunction, again, because the force of blood coming into the penis may not be as strong. And similarly, of course, cardiovascular disease. If our heart is not functioning as well as we'd like, then again, we're not going to get that strong blood flow pumping into the blood vessels of the penis when we want it to go there. So along those same lines, or I should say along the lines of men with diabetes being at higher risk for erectile dysfunction, unfortunately, men with diabetes are at higher risk of developing heart disease as well. And really, it's the exact same mechanism because that sugar in the bloodstream can be deposited in the blood vessels of the heart the same way that it can in the blood vessels to the penis. Coronary artery disease can develop just even 2 to 3 years after the development of erectile dysfunction in men with diabetes, and after the development of ED are at higher risk for heart attacks and strokes as quickly as 3 to 5 years after we diagnose erectile dysfunction. So it's very important. I guess the idea here is that certainly when we're talking about erectile dysfunction, we're talking about sexual function, right? And we're talking about that part of life. And I think the important thing to take away is that, yes, that's a very important part of life. That's what we're here to talk about this evening. But sometimes ED can be the first sign of something more serious going on, and certainly worthwhile to get in to talk with a physician about that. Let's talk a little bit about the relationship between erectile dysfunction and heart disease, kind of independent of diabetes. So sometimes when men have difficulty with their erections and are not responding well to medications like Viagra or Cialis, I will commonly do a test in my office that's called a Duplex penile ultrasound. It's just a blood flow study to measure the blood flow in the penis to see how healthy the blood vessels are. Even when men have perfectly healthy blood vessels carrying blood into the penis, they are tiny. They measure 0.1 to 0.2 millimeters in cross-sectional size. So the diameter is just tiny for these blood vessels. The diameter of the blood vessels that goes to the heart is several fold larger. But the same process that can lead to a decrease in blood flow to the penis can, over time, lead to a decrease in blood flow to the heart. And again, more emphasis on the fact that ED can be a vital first sign that we can catch to then ultimately improve or prevent other issues down the line. This is another sort of representation of the difference in the size of the arteries. As we can see here, the diameter of the penile artery is, here we see 1 to 2 millimeters. It's really 0.1 to 0.2. But the artery supplying the blood to the heart, 3 to 4 millimeters in size. The carotid arteries carry blood flow to the brain, and the femoral artery carries blood flow to the legs. And the point here is, if we're starting to have symptoms of heart disease, if we're having symptoms of pain with walking that might represent decrease in blood flow to the legs, this is something that typically happens several years after the development of erectile dysfunction. So we can really jump on things early and make lifestyle changes for improvement in overall health. So whenever I'm talking to a man about erectile dysfunction, I think it's important to talk about some of these lifestyle things that are both crucial to our penile health, but then also crucial to our heart and vascular health. So we always harp on things like diet and exercise, right? And we do so because those are important things that really work. Now, I have to be honest, changing diet, increasing physical exercise to 30 minutes of cardiovascular exercise 3 times a week, it's probably not going to reverse the effects of erectile dysfunction, but it certainly is going to help prevent things from getting worse and is going to help prevent some of these other health issues that we know can occur down the line. If men are smokers, we recommend, of course, that we quit smoking, and we also recommend stopping smokeless tobacco because whether it's cigarettes or vaping or dip or chew, these things all cause our blood vessels to clamp down, which decreases the blood flow and makes it so that it's more difficult for those vessels to open, for example, when we want them to open for sexual activity. Stress reduction is a very important thing and something that I think we're all feeling a little bit more of here during the times that we're living in, shall we say. Nevertheless, stress certainly plays a role. We know that there's a psychological component to erectile dysfunction for most men, even if it's just the frustration of the physical problem that we're having. But nevertheless, working on that is an important part of heart health and sexual health. So let's talk a little bit about erectile dysfunction and low testosterone. Many of you who are on the presentation this evening may have heard an advertisement for this evening's event on 97.1 or on one of the other local radio stations. And you probably have also heard ads on those radio stations about testosterone, because testosterone is a very big topic these days. Low testosterone occurs when a man's body produces less testosterone than normal. And dare I say, this is a fairly normal process that occurs throughout our lives. In fact, our testosterone peaks at age 25 and declines very gradually from that point forward. And so as our testosterone declines, though, we may develop some clinical or some symptomatic effects of that, including the risk of sexual dysfunction, a decrease in the feeling of general well-being. There can be some changes because of the way testosterone helps our metabolism. There can be some changes in terms of weight gain and other body composition. We know low testosterone is very common, and it's also more common in men who have diabetes. I know we keep kind of bringing that up, but it's absolutely the case. It's also more common in men who have what we would term the metabolic syndrome, which is this combination of blood pressure issues, high cholesterol, and potentially obesity will also cause our testosterone to decline. Lots of different signs and symptoms to low testosterone. And as I commonly say to my men that I take care of for testosterone, one of my jobs with testosterone is to not overpromise and underdeliver, because there are a number of different things that low testosterone can manifest. And I want to be careful about saying that we don't necessarily fix all of these symptoms with testosterone replacement, but many of them we would expect to see benefit. We often will see loss of energy. We'll see symptoms that are overlapping with depression symptoms, lack of interest in normal activity, a decrease in libido is a common one. The overlap between our testosterone and our erectile function is not a one-to-one ratio. It's not as if our erections get stronger as our testosterone goes up, but certainly if a man has a lower than normal testosterone, we know that replacement of testosterone is likely to help a man achieve the best erection that he possibly can, with or without medications or other treatments. Treatment for low testosterone, there's a number of different options available to us. Testosterone gels or patches can be used as what we would term topical therapy, where we're essentially placing testosterone on the skin. It's then absorbed through the skin to get into the bloodstream that way. Oral medications, there's one FDA-approved oral testosterone medication. Quite honestly, I have not used very much of that yet, because I think the jury's still out about whether that's going to be as safe and effective as our other options. Sometimes we use testosterone injections, where it's fairly common in my world to teach men how to inject testosterone either into the thigh or into the rear end once every 2 weeks to replace testosterone that way. We also have testosterone pellets that we sometimes place underneath the skin that give replacement that lasts for about 4 months or so. Some men with low testosterone will take an oral medication called clomiphene citrate, which increases our body's natural testosterone production. So we have a number of different options that might be appropriate based on an individual man's levels, his symptoms, and what's appropriate for him. To transition a little bit to talk about ED and prostate cancer. You know, prostate cancer is something that, as a urologist, of course, I would take and do take very seriously. I treat many men for prostate cancer as well. I think we can go to the next slide there. But we have to acknowledge that, unfortunately, the treatment of prostate cancer does, I will not say can, I will say does lead to erectile troubles. And the reason for that is fairly straightforward anatomy. We can see here in this cartoon or illustration on the slide that the nerves that are responsible for telling those blood vessels in the penis to dilate, they happen to run right on top of the prostate gland, where they are both in the area that they might be injured during surgery to remove the prostate if we're having prostate cancer surgery or robotic prostatectomy. But it's important to say that those nerves are also in the path of radiation energy. If we undergo radiation treatments for prostate cancer, there might be damage to those nerves as well, which can lead to worsening erectile function as well. This statistic is fairly broad here. It says that erectile dysfunction overall affects 25 to 75% of men, but that 10% to 46% of men 1 year after prostate cancer surgery will have erectile dysfunction. And I think the reality is we would just say it's very common for men to have worsening erectile function after prostate cancer treatment and prostate cancer surgery. What I tell all of my men is that the expectation is if we don't need Viagra prior to prostate cancer treatment, it's very likely that we will need some form of medical therapy afterwards. And if we are already at a point where our erections are not so great before treatment or certainly surgery for prostate cancer, we're going to have a serious conversation about some other treatment methods in order to restore the erectile function afterwards. Peyronie's disease. Peyronie's disease is a disease of penile curvature that occurs because of the development of some scar tissue in the penis. Every time we have erections, every time we have intercourse, there are microscopic traumas that exist to the erectile tissues of the penis. In the majority of cases, those micro traumas are healed with healthy tissue. But for some men, for reasons we don't fully understand, although I will again bring up diabetes because we know that Peyronie's disease is more common in men with diabetes. But for reasons we don't fully understand, for some men, instead of healthy tissue, we develop scar tissue in the erectile bodies of the penis. And the way that that manifests is most commonly with pain with erections and potentially penile curvature or narrowing of the penis, or what we sometimes refer to as an hourglass defect, where during an erection, we can see the sides of the penis are very narrow in one area. Peyronie's disease is a very difficult disease to have. It's a very difficult disease to treat. It can result in severe difficulty or inability to have sexual intercourse because the curvature, quite frankly, just makes it mechanically impossible. Oftentimes, the curvature will cause pain for men or for their partners as well. Erectile dysfunction is also associated with Peyronie's disease because of the severity of the scar tissue and oftentimes because of the anxiety and stress that's involved for patients and for really the desire then to avoid sexual activity at all because of the difficulties that they're having with the disease. Peyronie's disease is something that tends to come on fairly quickly. It tends to start with some vague discomfort in the penis, but oftentimes very rapidly can then transition to the development of a curvature. Commonly, we can feel the scar tissue in the penis, so guys will sometimes feel a lump in the penis, and oftentimes guys will have very legitimate concerns about whether that lump in the penis is representative of something potentially even more serious. And if there's any good news, it is that Peyronie's disease does not spread and is not a sign of any other disease process, for example, penile cancer. However, that lump is typically the scar tissue that is causing the curvature and potentially the difficulty with erections. The other thing that is very devastating, both for men with Peyronie's disease and if I'll could spend a couple of minutes talking about men with ED as well, is shortening of the penis. One of the things that happens with Peyronie's disease is that the scar tissue, as it heals, it contracts. Anybody who is viewing this presentation who has any scars on their body can say that when a scar heals, it kind of causes the skin to pucker a little bit. Well, the same thing happens with Peyronie's disease and our penile length. That tissue basically puckers in, and guys oftentimes legitimately will have lost even 2 or 3 inches of penile length because of this scar tissue. That same process actually can occur with erectile dysfunction as well. You know, we've been talking so far this evening about sexual erections because that's, of course, the erections that we want to be having. Those are the erections that we notice we lose and are the reason, of course, that we seek treatment. But the reality is, before we start losing our sexual erections, most men have also lost the nighttime and early morning erections that ideally are happening half a dozen times or so every night, and which are responsible for maintaining the health of our penis. If we're not getting those nighttime erections 5-6 times a night, the erectile tissues of the penis will gradually kind of scar down because they're not getting that healthy blood flow. And that also can lead to loss of penile length. This is oftentimes most prevalent in my men who have surgery for prostate cancer. It's almost every day I'll meet a guy who says, it seems like immediately after my prostate cancer surgery, I lost an inch or 2. And the reality is they probably did, because they went from having 5 or 6 nighttime erections every night to having 0 literally overnight. And so the change is very dramatic, more so than the change might be over several decades with a gradual loss of erectile function. There are fortunately several treatment options for Peyronie's disease, and we're very fortunate these days to have an FDA-approved non-surgical therapy for Peyronie's disease, which is something called Xiaflex. Xiaflex is a medication that is actually injected into the scar tissue and causes the scar to soften up, essentially to melt away in order to improve the curvature. Surgery for Peyronie's disease is still something that we do very regularly. Plication is a surgery where if the penis is curved in one direction, we put stitches opposite the curve that are obviously deep to the skin where we can't see them, but we tension those stitches so that the penis is straight. Effectively, what we're doing there is shortening the long side of the penis. So plication surgery is not a great option for guys who have lost significant penile length. Nevertheless, can be a great option to immediately fix the problem. Incision or excision and grafting refers to going in and actually removing the scar tissue. When we remove the scar tissue, we typically regain some of the length that has been lost. The challenge is when we remove the scar tissue, by definition, we've violated the tissue that holds the blood in the penis at the time of an erection. And so a graft material is sewn in place in a watertight fashion to allow for normal erectile function in the future. Penile implants for erectile dysfunction and Peyronie's disease are something that we do very commonly because with a penile implant, we're able to both restore the erectile function and we're able to straighten the penis through some maneuvers that we perform in the operating room, and quite frankly, because of the rigidity and strength of the implant, will cause gradual straightening of the penis. So let's shift gears a little bit. We've talked about the medical problems that are associated with erectile dysfunction. We've talked about what it is. Now let's talk about what do we have available to us to fix this devastating problem. So the first thing that we talk about is kind of an overview of our different treatment options. We'll talk about oral medications. These are the Viagra, Cialis of the world. We'll talk about injection therapy. It's very common in my world to teach men how to inject medication directly into the penis, which causes the blood vessels to dilate. really nice option for men with diabetes, as we'll talk more about in a moment. We'll talk about vacuum erection devices. We'll talk about urethral suppositories, which is another way of delivering medication to the erectile bodies. And of course, we'll talk about penile implant as the only restorative option for erectile dysfunction. So oral medications, or what are known as phosphodiesterase 5 or PDE5 inhibitors. These medications, and of course, as many of you are aware, there are several of these medications that are out there in the world: Viagra, Cialis, Stendra, Staxin, Levitra, and then there are generic versions of all of those things. Effectively, the way they work is by increasing the blood flow to the penis. Way back at the beginning of this presentation, we talked about how there has to be some communication between our nerves and our arteries in order for the arteries to dilate for the blood flow to come in. Well, the way that these medications work is they cause the signals that are released by the nerves that tell the arteries to dilate. This is that nitric oxide stuff. PDE5 inhibitors cause the nitric oxide to hang around longer, so it has more of an effect on the arteries. It's important to say that this is only going to be effective if the nerve and artery communication is intact. The medications are also only going to be effective in the setting of sexual stimulation. We can't just take a Viagra pill, sit back and wait for the magic to happen. We still have to be in a normal sexual environment and those kinds of things for the pills to be effective. Typically, the medications are taken about an hour or so before anticipated sexual activity. And we have a window of time inside of which they're going to be effective. For Viagra, it's about 4 hours. For Cialis, it's about 36 hours. And that just has to do with the way the body metabolizes these different medications differently. It's important for us to say that we can't take these pills more than once a day. And the benefit or the efficacy of the medications is affected by food and alcohol. So when I'm counseling men about taking these pills, I always endeavor to say that they're going to work best when taken on an empty stomach and in the absence of alcohol. The obvious downside there is we can't go out for a nice dinner, take a Viagra when we get home and have as much of an effect or an expectation that it's going to work. Nevertheless, that's just something we have to be aware of. Pretty broad efficacy rates here. You can see 50 to 85% of cases. The statistics that I think are a little bit more relevant are what's below there. Almost half the men with ED after prostate surgery are going to give up on the pills because they're not effective. And that really has to do, again, with the fact that unfortunately there's commonly some damage to those nerves during treatments for prostate cancer that make the pills less effective than we'd like. Similarly, because men with diabetes are going to have an issue with the nerve signaling, they are much less likely to respond to Viagra or Cialis because, again, we have to have that intact nerve and artery communication to be effective. What are the downsides of medications like Viagra and Cialis? Well, these medications cause our blood vessels to dilate. That's, of course, how they help with our sexual function, but they can cause blood vessels in other parts of the body to dilate. So we might get increased blood flow to the face and get facial flushing. We might get increased blood flow to the head and develop a headache. We might have nasal stuffiness. We might have muscle aches. We might have acid reflux. All of these things are potential side effects of the pills, but are self-limited, meaning they're going to go away as the pills kind of wash out of the bloodstream. It's important to say that we cannot safely give men who have significant cardiovascular history medications like Viagra or Cialis. Men who have had a stent placed, even men who have had open heart surgery, oftentimes it's very safe to take these kinds of medications as long as it's okay with your cardiologist. But there are certain medications, specifically nitrates, that cannot be taken with these pills because they will cause an unsafe drop in blood pressure. Similarly, I recommend that we not start Viagra the same day that we're starting something like Flomax to help with our urination, or a new blood pressure pill or anything else that might affect our blood pressure. We want to wait until we're stable on those other medications before trying the Viagra. Vacuum erection devices are a very nice non-medical, non-surgical treatment for erectile dysfunction. I'll quickly pause here and address a question that just came across about whether pericarditis is a condition that would eliminate Viagra as an option. As many people on this presentation are aware, pericarditis is a condition where the lining that surrounds the heart becomes inflamed. This can happen because of a viral infection. It can happen because of too much alcohol. In fact, pericarditis around holiday time is affectionately referred to in medicine as holiday heart because it happens very commonly. But regardless of the reason that we've developed pericarditis, it is safe to take Viagra with pericarditis once it's resolved. So if we have a history of that, that's okay. If we have an active inflammation of the lining of the heart, we'd want to hold off. Vacuum erection device is essentially a hollow cylinder, a hollow plastic cylinder with a rubber gasket at the base that is placed over the penis, forming an airtight seal with the skin. There's then a hand pump or sometimes a battery-powered pump that causes negative pressure to draw blood into the penis for the erection to occur. We typically would use a vacuum erection device along with a constricting band that goes around the base of the penis to hold the blood in the penis. Some men use a constricting band even without a vacuum device, which can be very appropriate. But nevertheless, we would typically always have to use one with a vacuum device. Satisfaction rates for the vacuum device can be fairly high for the men who like using them. And I frame that very intentionally because they can be a little bit cumbersome to use. They're certainly not spontaneous, and they can cause some discomfort of the penis, as we'll see a little bit more on the next slide. So the most common side effects, blocked ejaculation. Well, we talked about placing that ring at the base of the penis. That's going to compress the urethra tube, which is going to make it so that our ejaculate does not come out the end of the penis. Obviously a very bothersome thing for some men. There can be bruising, discomfort of the penis. The biggest complaint that I hear from men's partners is that the penis is cool to touch instead of being warm the way that it is with our sort of arterial blood flow. And that's because the blood that fills the penis with a vacuum device is from the veins, not from the arteries. And so we can see here the most common reasons for discontinuation are those side effects and again, the lack of spontaneity. Urethral Suppository, or what's called the Muse Suppository, is a medication that is delivered by an applicator that is placed in the tip of the penis. The Muse is a small pellet that then passes through the applicator into the urethra tube. Once that pellet is in the urethra and the applicator's been removed, the penis is massaged, which causes that pellet to break down, giving medication that dilates blood vessels to the erectile bodies of the penis. Typically, about 5 to 10 minutes after kind of massaging that pellet is when we would expect the erectile response to begin. You can see the success rates that are reported. In my experience, I have a handful of guys who really swear by the Muse Suppository, but my experience tends to be that which you see here from the literature, that discontinuation is fairly high because typically of the need to place that applicator in the tip of the penis, which causes some pain and potentially burning with urination after sexual activity. Because this medication dilates blood vessels, it can potentially cause a drop in blood pressure, although fortunately that is quite uncommon. Typically we don't see any blood pressure issues here. But the most common reasons that guys stop using the Muse Suppository is just that it doesn't work quite as well as some of our other options. The exact same medication that exists in the Muse pill form can be given by injection. And so intracavernous injection therapy is the idea of injecting with a very small needle, a very small volume of medication directly into the erectile body of the penis. This is a very effective method to treat erectile dysfunction because by delivering medication directly where we want it to work, we bypass that communication between the nerves and the arteries so that we can have the effect that we're looking for. Typically about 5 to 20 minutes, I usually tell guys about 10 minutes or so after the injection is when we would expect the erectile response to begin. So usually from a mechanism standpoint, what I recommend guys do is, first of all, who doesn't visit the restroom to empty their bladder before sexual activity? That's a very common thing that we would do. So perhaps we take that opportunity to perform an injection and then we initiate foreplay. And when it's time to be ready, we're typically going to be ready by then. So it can be a very effective sort of mechanism that way. About 60% of patients, based on some studies, are satisfied and continue the use. Long-term use of injection therapy tends to be fairly uncommon just because of the discomfort of needing to stick ourselves with a needle. It is, of course, a sensitive part of the body, but generally speaking, guys do very, very well with that, and the discomfort is minimal. There are, of course, some side effects of penile injections. Stands to reason that if we continue to stick the same part of our body with a needle, we might develop some scar tissue. In fact, intracavernous injection therapy is a potential risk factor for the development of Peyronie's disease over time, so we have to be aware of that. It is possible to overdose on injection therapy medications. Everybody has seen those commercials on the TV for Viagra that say if you have an erection that lasts longer than 4 hours, you got to call a guy like me. The reality is that's never going to happen with Viagra, certainly as long as we don't take it with other medications that dilate blood vessels. But with injection therapy, it's very possible that it could. And so we need to be careful about the dosing. So we always teach men how to perform those injections in the office. Sometimes I will perform that ultrasound of the penis that I made reference to earlier in order to figure out what a man's blood flow is and therefore what the appropriate dosage should be for this kind of medication. If we do have an erection that lasts longer than 4 hours, well, unfortunately, that may require an injection of different medication to reverse the effect. Again, all the reason to be very careful about this. We might have a little bit of bruising from the needle stick as a potential side effect as well. And of course, the reasons that men would stop injection therapy are all the reasons that we could all guess. We get tired of sticking ourselves with a needle. We don't like the fact that the medication has to be refrigerated at least, or commonly frozen if it's going to be kept for longer periods of time. And of course, if the erectile response is not good, then we're going to stop therapy. I should say that there are really about 24 different formulations of injection therapy that we can choose from. So it's common for us to shift those things around over time in order to find the correct medication for a man who does want to do injection therapy. So let's talk a little bit about the penile implant. I made reference earlier to the fact that the penile implant is the only restorative treatment for erectile dysfunction. And the reason that I use that word is that once a penile implant is in place, once a man is comfortable using it, it's going to function consistently and well each and every time, just like when we used to get those erections when we were 23, whether we wanted them or not. The penile implant is comprised essentially of 3 components. There are paired cylinders that go into the erectile bodies of the penis. There's a pump that's then placed in the scrotum in between the 2 testicles where we can feel it through the skin of the scrotum. And there's a reservoir that's placed in the groin area intentionally where we cannot feel it. That reservoir is filled up with sterile saline, or essentially a saltwater solution. And at rest, the cylinders are empty of fluid. When we want to have an erection, we squeeze that pump, which we can feel through the skin of the scrotum, that moves fluid from the reservoir into the cylinders, which become longer and rigid for the erection to occur. The efficacy of the penile implant is extraordinarily high. 98% of men with a penile implant report their erections to be excellent or satisfactory, and out 7 to 10 years, 94% are still in use and free of revision. Importantly, 95% of partners of men with penile implants also report that their experience is excellent or satisfactory as well. Side effects, most commonly of penile implant, post-operative pain. Well, my joke with my guys in whom I place a penile implant is that for the first week or so, you're going to use my name as a curse word because it's fairly common for guys to be fairly sore for the first week or so after the procedure. We don't realize how much of our daily life is spent sitting on or compressing or just generally kind of touching the penis, whether it's just our jeans or again, sitting on a chair. But for that first week or so, it's difficult to find a comfortable position, although that resolves very, very quickly. Mechanical malfunction, including something called auto-inflation, is fortunately a very rare occurrence. It should be said that the average lifespan of a penile implant is about 10 years or so. And if a penile implant develops a mechanical failure, what that really means is that there's a crack that has developed somewhere in the system, allowing that saline solution to exit the implant. I think it's important to say that that saline solution is sterile. It doesn't travel throughout the body. It doesn't cause any harm to the penis or other tissues locally. It simply means that unfortunately, we might squeeze the pump and not achieve an erection. If a man develops a mechanical failure, it's a fairly straightforward process to remove the old implant and place a new one. Although, of course, that does require a procedure in the operating room. Infection is fortunately also a very extraordinarily rare event, occurs in about 0.5% of men who undergo penile implant surgery. We guard against the development of infection at the time of surgery by giving guys antibiotics through the IV prior to surgery, by washing the tissues with antibiotics during the procedure. And we even have implants such as the Boston Scientific implants that are coated in antibiotics to help further reduce the risk of infection. So with all of those things put together, infection rates are extraordinarily low. I should say that a penile implant is placed in a procedure in the operating room that typically takes about 30 to 45 minutes or so to do. Typically what we do is make an opening in the skin that's about an inch or maybe 3/4 of an inch in size. And through that single opening, we pass all the components of the implant. About 50% of the time, guys go home the same day from that surgery. The other half of the time, I keep guys overnight, one night, and it really is individual preference, unless, of course, there's a medical issue that a man might have that makes us say the safer move is to stay in the hospital overnight for one night. A question has come through that is really a spot-on question, and that is, will patients have the same sensation with an implant as they do prior to having an implant? And the answer is yes. The implant does not change anything about penile sensation. It does not change anything about orgasm or ejaculation. It simply allows us to restore our erectile function. There's another good question here from just a moment ago, asking about whether taking Flomax over time will affect our ability to obtain satisfactory erections. The interesting thing is that there is some data that has started to come out that suggests the answer to that question might be yes. Both Flomax and finasteride, which are two common pills that we would prescribe for enlarged prostate to help with urine flow, both carry a risk of worsening erectile function over time. And so when we're thinking about the risks and benefits of different treatment options for BPH, that's where we might, for some men, consider other things like green light surgery or other procedures for the prostate in order to open things up and be able to stop those kinds of medications to have the outcomes that we're looking for. I believe next we have an illustration here, or a video rather, that sort of demonstrates how the penile implant is sort of put together and how it works with the pump and the reservoir. So obviously in this animation here, what we're going to see is the penile implant inside the body with the cylinders that are being inflated as in this animation the pump is being squeezed. So as the pump is squeezed, fluid moves from the reservoir into the cylinders for the erection to occur. The erection is going to last as long as we want, because the only thing that tells it to go away is a release valve, which is part of the pump. And as we squeeze that release valve, the fluid will move passively back into the reservoir to go back to the flaccid state. Sometimes in my practice, it's common to discuss with men the issue of premature ejaculation. And one of the positives of the penile implant is that premature ejaculation can be overcome by the fact that the erection is not going to go away until we want it to do so. A question about kidney disease and erectile dysfunction. Specifically, can kidney disease affect or potentially even lead to ED? And the answer to that is also yes, in a couple of different ways. First of all, it's common when we have kidney disease to take medications in order to maintain or even improve our kidney function. Those things can be life-saving. They're absolutely essential, but some of them decrease our blood flow and may lead to ED. Chronic kidney disease also affects the health of our blood vessels and can make it so that the blood flow to the penis is not as good as it used to be. And certainly things like dialysis can affect the health of our blood vessels in a similar way. A question has come through that reads, what if one is able to achieve some degree of erection, but is having difficulty achieving an orgasm and ejaculating? And in my office, we take great pains to make sure that we're talking about specifically the problems that men are having, because we're really talking about three different things here. We're talking about difficulties with the erection. We're talking about orgasm, which is the pleasurable sensation at the climax of sexual activity, which occurs because of spasming of muscles around the prostate and the urethra. And then the third thing we're talking about is ejaculation. Well, for most of our lives, these things are linked, right? Erection leads to orgasm, which leads to ejaculation, but they're all separate processes. Some men have difficulty with the erections, but the orgasm and ejaculation is just fine. Well, then we manage that problem. Some men, as this question identifies, are able to do okay with their erections, but they have trouble reaching orgasm. So then the question becomes, are we having difficulty reaching orgasm because the erection goes away too soon? If so, well, then we manage that issue. Are we having issues with orgasm because our sensitivity is not what it used to be, because we're not as young as we used to be, or we have some other medical problem like diabetes again that can cause that issue? Well, if that's the case, then I recommend warming lubricants, personal warming lubricants, which are available over the counter, you know, at the drugstore, that are often marketed, for example, by KY as personal warming lubricants. Those can help the stimulation of the tissues. Sometimes we use medications to help promote ejaculation, even things like pills, or nose sprays of something called oxytocin we sometimes use to help promote ejaculation. It's important to say that men who have had prostate cancer treatment oftentimes will have orgasm but have no ejaculation. And that is, dare I say, normal for those men, because if the prostate gland has been treated or removed, then the source of the fluid that comes out at the time of ejaculation has also been eliminated. So in summary, the benefits of the penile implant are that they're really designed as a permanent solution, a restorative option for erectile dysfunction. They are, of course, spontaneous. We can use the implant whenever we want to, and it's going to be there, and it's going to be effective when we want it to. Again, the erection is going to last as long as we want. The implant's completely contained within the body, I should say. So nobody's going to know that a man has a penile implant unless he wants them to know. Showering at the gym, not a problem. Nobody's going to know unless it's someone that we want them to know. Implants have been in use for several decades. Implants have been around longer than any of the other things that we've talked about. Injection therapies, the Muse suppository, certainly Viagra, and of course the implant has undergone several generations of improvement to have the effective solution available to us that we have today. So a question came through about implants and insurance. Fundamental question. Thank you for asking it, and I apologize for not bringing this up independently. The penile implant is covered by most private insurance and is also covered by Medicare. Men who have Medicare and have a Medicare supplement will often have very little out-of-pocket cost, and we always pre-authorize the procedure beforehand to know what the out-of-pocket cost is going to be, certainly in the case of private insurance. So we have a mechanism, of course, in place for looking into this to make sure that there are no surprises. There was also a question about whether his wife will notice a difference with the implant. And the answer, again, I'd refer back to that 95% partner satisfaction rate, where partners generally do not notice much of a difference other than the fact that we have an erection that works, that is rigid enough for sexual activity, and that lasts as long as we want. I saw one of my post-operative patients today in the office who jokingly told me that he knows how to inflate the implant, but only his wife knows how to deflate it because she keeps track of making sure it's erect as long as she wants it to be. So I think it's something that partners are generally very satisfied with. This is a great question. Why does a strong erection occur in the morning and then dwindles during the day? And then they say taking Cialis. That may have something to do with the testosterone levels. I hear from guys all the time, I wake up in the morning with an erection and I can't do anything with it. And then when I want to get one later on in the day, we don't have any function. And the reason for that is our testosterone levels are highest in the morning, generally between 8 and 10 or so in the morning, which is why we might be able to have a better erection earlier in the day as opposed to later in the day. And a follow-up. This is someone who is taking testosterone injections. So sometimes it has to do with the way that our brain sends signals to the erectile bodies of the penis. The reason that we get those nighttime erections is not because it's a, shall we say, a comfortable environment or anything along those lines. The reasons that we get nighttime erections is that the signals that are normally coming from our brain telling our penis not to become erect are lost during REM sleep. And so if we're emerging from REM sleep, we might have one of those erections, whereas what we're doing when we're having sexual erections is we're trying to overcome those inhibitory signals, and sometimes the blood flow, unfortunately, is just not strong enough to achieve that. Okay, we have a little bit of a longer question here. So this is someone who had a procedure for enlarged prostate that we call a HOLEP procedure, which is a procedure where we use a laser to remove enlarged prostate tissue. It says the procedure has worked well, and we're having initially nighttime and early morning erections that are even larger than we had before the procedure, but now 2 months out, we have a certain degree of erectile dysfunction. So really the fundamental question here is what's happening with the blood flow. And again, in my office, this is a circumstance where we would commonly move to a duplex penile ultrasound to evaluate the blood flow to try and get a better sense of why is this happening. Is there some issue with nerve signaling? We know that with a HoLEP, although the energy is confined primarily to that central portion of the prostate gland, if those nerves received a little bit of that energy, they may gradually function a little bit less well, which can account for some of the changes that might occur over time. We also would want to see what's the arterial blood flow. Is this more situational, or shall we say, is this correlation or is it causation? Does it have something to do with the HoLEP or not? But that's how we would typically evaluate things in the office. Question about achieving erections when fantasizing versus when with a partner, and this is a great question that that I get in the office all the time. It's a question that I often ask guys: are we having trouble with masturbation? Are we having trouble with intercourse? Are we having trouble with both? And this really speaks to where sometimes a sex therapist can be a very helpful part of the overall process. Of course, as a urologist, I focus primarily on the medical side of things and the blood flow side of things, but it's very common for me to put a man through a series of histories and physical exam and maybe even a duplex ultrasound for us to find that maybe the issue is a little bit more communication between a man and his partner, and that's where a therapist can be very, very helpful. So that's an avenue we often explore. All right, well, it's about 10 minutes after 7 or so. I think we talked about many of these risks of the penile implant in terms of the fact that if the implant does develop a mechanical failure and has to be removed, we would have to replace an implant in order to continue with sexual function. We would not have to remove a penile implant for a man's health. It's safe to keep that in place essentially forever without much risk. Pain, again, is typically a temporary process. And men who have diabetes, spinal cord injuries, men who are smokers, I find are at higher risk for developing a penile implant infection. So we have to be very careful about that, of course. All right. Well, I want to thank everybody for their participation and communication this evening. This is, again, a topic that is very dear to me and something that I spend most of my professional life working on. I'd be happy to see anybody for further discussion, or would encourage you to, if you are already established with a urologist, to speak with them about any of these issues, and we can move the care forward. And I think maybe I'll take this as the last question of the evening, which is spot on to something that we were talking about previously. Can metoprolol cause ED, and would it be safe to use Viagra and Cialis? And the answer to both of those questions is yes. Metoprolol is a medication that decreases our heart rate and blood pressure and therefore can cause some erectile issues, but it is certainly safe to use Viagra and Cialis once we're stable on the metoprolol in order to improve our erectile function. There's a link here, edcure.org, that I would encourage you all to go to. May have already done so in signing up for things this evening, but nevertheless, edcure.org, great resource for all these things that we've talked about this evening, more resources about erectile function, and of course, penile implant, and further questions. So again, thank you all very much. I appreciate your time, and have a great rest of your evening.